Welcome to this webinar on Corona in the world in Corona. The objective of this webinar is to come together with the students, alumni, staff members of ITM and IOB, the Institute of Tropical Medicine and the Institute of Development Policy to reflect on the current situation. This webinar is at the same time an opportunity for others as well, people directly or indirectly involved in the networks of both the IOB and ITM to join in and participate in this reflection. The central question before us in this webinar is what is happening to us and how can we make sense of it, also from our own field of interest, development studies or public health. On one hand, we can conceive of this virus as a mirror in which we can read the world. If we are looking at how the virus is developing and spreading and being managed by different countries, different types of health systems, political systems, social systems, what can we learn about these systems? But on the other hand, we're also actors in this crisis, more than ever. And we want to know what to do. What is this virus? What are our options to respond to it? What can we expect about the future? And how can we anticipate the next crisis? On the program, we have in fact two sketches of the situation. One by Professor Wim van Damme, who is head of the International Health Policy Unit at ITM and currently working and residing in Kinshasa. And another sketch of the situation will come from Alex Delamou, who is a medical doctor and working in Guinea. So this will take about 10 minutes, after which we will give the floor to Willem van de Put, who is a medical anthropologist also at the Institute of Tropical Medicine here in Antwerp, and who will talk and give a more of a contextual analysis of the situation. After this, and then we're more or less around 5 o'clock, we start questions and answers. And you can already start formulating your questions by making use of this Q&A button at the bottom of your screen, or perhaps it's at the top of your screen. It depends on how Zoom has been configured in your case. So you can type your questions, and others could add other questions, or they could also push one question they think which will be important or interesting. And then we will engage in this Q&A after 5 o'clock. There's one final point perhaps before I give the floor to the situation sketches. You can move the images of the different panel members. You can move them around. You can also minimize them in order to get a broader view of the presentation. I think that's all for now. So I will end sharing my screen and give way to the sketches of the situation.
Hello, this is Wim van Damme from Institute of Tropical Medicine here in Kinshasa. I'm happy to share with you some insights on the situation in Kinshasa here. I will cut my talk in 3 parts. The first is a brief summary of the situation as it is now in Kinshasa. The second is about the challenges, and the third is some reflections on the situation. As some of you know, I like usually to use the blackboard, but as I don't have one available here, I use these other old-fashioned tools. So first on the situation as it is now in Kinshasa. Till now, there have been approximately 100 cases of coronavirus infection documented, and 8 of these patients have died. Roughly half of these infections were imported, people who came from Europe or the US, mostly what they call here VIP, high-level government or business people from Congo, who came from Europe or the US. There have been also some 50 cases of local spread, mostly close contacts to this VIP. So the consequence of that is that almost all cases are in the very center of Kinshasa. And hope is to contain the epidemic here, but there is already some further spread. So in the cité, the popular slums, where the large majority of the people in Kinshasa live, through contacts, driver or house staff of these VIPs, and a few worrying cases in the rural areas, in Bujimai, in the Kasai. Person who came from Europe traveled to Mbujimai, gave big party and big celebrations, fell ill, had very intensive contact with very many people, and then died. So that is being investigated. There is also a case in Ituri, in a mining area, and and a few other alerts. So the measures taken are the classic measures that are taken in most parts of the world: restrictions on air travel, limitations of local gatherings, schools closed, churches closed, very limited number of passengers in cars and buses. Active case finding, people concentrated in 7 designated hospitals, contact tracing, information campaign, special social distancing, promotion of that, and also promotion of hand washing, home quarantine. All this is very nicely coordinated by the famous professor Jean-Jacques Muyembe, who is very well known for his role in all the Ebola epidemics that occurred here. And many of the measures taken are similar to Ebola, although the disease is, of course, now much less severe. So there is an extensive Congolese corona response team, and they say very, very clearly we will not repeat the same mistakes as in the Ebola. No parallel system. Everything will be integrated in the Congolese system. We will strengthen our health system. 3 days ago there was a bit hiccup. It was announced there would be total lockdown in Kinshasa. This created panic, and that was a few hours later cancelled. So this was the first part.
Good afternoon, this is Alex from Conakry, Guinea in West Africa. I just want to give you a quick update on this coronavirus pandemic in my country. As of today, we have recorded 22 confirmed cases with 1 recovered. And the bad thing is that 2 of the confirmed cases are now from community transmission, which is very scary. And a week ago, the country was locked down, and also a state of emergency was declared in the country. As you can see, I'm working today from home because we have to change our habits, and most of our meetings at the Maferenya Training and Research Center where I work, and also at the University Gamal Abdel Nasser of Conakry, where I am a faculty, have to be done virtually. The university and all the schools across the country have been locked down for 2 weeks, and this measure will probably be renewed. So the pandemic is, of course, very scary because our country have the experience of the Ebola outbreak in 2014 to 2016, and we are concerned if our health system will be able to face this new epidemic. And that's why I am coordinating an initiative to conduct a situational analysis of this pandemic in the country with the support from ITN and also from ENABEL. We will be conducting a nationwide knowledge, attitude and practice survey, and also a disease preparedness survey to provide evidence-based data to our authorities and to better guide the prevention and control measures that are ongoing. 2 days ago, we were informed by the National Sanitarian Agency that 300 contacts are not being followed as they should be because they are not responding to the calls. And so we are concerned as to whether those 300 will not spread the disease within the community, as we are now recording some community transmission cases. And we will continue to pray, but also to do whatever we can to stop the spread of this disease in the country. Okay, thank you very much. Keep safe and keep fighting until we stop this pandemic across the world.
This is Willem van der Put talking from the Institute of Tropical Medicine. And I'm trying to give you an overview of all the different aspects of the corona crisis. And let's start quickly with what the current situation is. This is an update of today of the World Health Organization, the dashboard that they have on the coronavirus, and we can see how it spreads all over the world. In this session, you have seen in the invitation that these are the issues that we would like to cover, and the time is limited, so I will talk a little bit fast to get the issues covered before we get into an interactive discussion. This slide shows, I think, quite clearly how fast this has all developed. Within 3 months' time, we have all over the world 30,000 people who have died, and many more who are infected. This is in the slides, which you will be able to access later on. You will find all the links that are relevant to see all this in real life exchange mode. We know that the virus now has a long history. There's a long history of pandemics and epidemics in the world, and this is the latest one. And we also know that there is a lot to say about everything that happened. So please abide with me. There is covering the world in 40 minutes is something that well, they used to have 80 days to do it. Now we only have 40 minutes. So let's give it a try. I will give you the dimensions that I would like to talk about, the different dimensions of the coronavirus. And this slide is going a bit faster than I thought, but let's talk about the structure of the governance in pandemics. As you see, this is the organogram of the WHO, the World Health Organization. This is the official, let's say, governance that should be guiding us through the crisis. But there is a bit of a criticism there. There is, in the international situation, there are many different players. There is the different countries, of course, there are all the different sectors that play a role. And as you can see on the quotes that I have put together, there is a lot that says that the international leadership is lacking. There is, and you have all followed the news, many countries can respond in different ways. There is a question about should the virologists say what to do or should the politicians say what to do. This is an issue that is important and that plays a big role. What I try to do in this session is to cover all those different aspects, to say a few words about the different things And I've chosen for this because 40 minutes would be just it's too small of a time to get into any of these subjects in depth. And I think it's useful to see how these things are connected, and that should make us realize how this is an opportunity to change things also. The health sector in itself could give us three different examples of how the different contexts in which the crisis unfolds puts questions to us as a research community. The health system is, if you look at all the different parts of the health system and you compare them just, in your mind very quickly with the low-income countries or situations and high-income countries, you see that it's very, very different indeed. You see that in terms, it doesn't even need explanation in terms of resources, finance, infrastructure. It all leads to inequity. That inequity is obvious in a way, but at the same time, the inequity was to be expected when an outbreak would occur. Question is, what are we going to do about it? The clinical guidelines that are shared all over the world are available. They should be available everywhere. And here is an example of the last update that was made here in Belgium of the clinical guidance that could be used by anybody. Let's look at prevention. The prevention has in isolation and being locked up, and was one of the things that first came out. First out of China, then in Europe. In Europe it was done very differently in different countries, but now it's spreading all over the world. And you can see on these pictures that while we cope with how to keep ourselves busy at home, other people are simply trying to get home. These are some pictures from the New Delhi railway station, but I think you've seen more recently on television. These measures, they take out, they work out in different ways in different contexts. And so the same thing works that way for the mental health challenges in epidemics. There are more mental health challenges than we usually think about in epidemics. And there is also now a very concerted effort made to make that mistake not again. There are new guidelines written by the International Agency, and you can click on them and you'll find them. And you'll see that there's a lot that happens on the short term, but also on the long term. I found it very interesting to read about encephalitis lethargica, which happens for years and years after the big Spanish flu. And the best estimate is that that was a kind of after effect, a psychological after effect of a pandemic that has rocked the life, the worldview of many people. It's too much to go into at this phase, of course, but here you can see, I think, how even these mental health guidelines are focused on countries that have the resources to deal with that. And as said, many countries do not have these resources. There are other things like the demography, the politics. There is if you look at the demography, for example, this is one of the guidelines that comes out on how old age and corona overlap in terms of making people vulnerable and having problems. But there are, of course, very difficult questions that come up. And the change in family structure in different countries makes it, in many countries, impossible to keep distance, to isolate people that are at risk. And then are some of the questions we don't want to ask, but they come up anyway. Like in this moment in different countries, you see where there's a lack of intensive care beds. How do we deal with people at a very high age? And even more difficult in terms of ethics is how many old people can we deal with, especially in African countries and Asian countries. There is quite a lot to do about the age of the population, which puts the health systems under quite some stress. There is the political issues. The political issues are, of course, very complex. And what we see here is that the debate in the newspapers and on the radio and television is a lot about the different elements of this. Authoritarian governments seem to do much better in crisis than the not so authoritarian. But the thing is, how does it work out, these different way that the governance is responding to it? How does that work out in terms of equity? And you see that here now that the corona crisis has reached the large cities in the south, there are horrible things happening. the pandemic leads to all kinds of other problems, and in the end, the question will always be how effective are the measures in terms of stopping the pandemic, and how effective are they in creating problems that come out as a result of that. The European Union has a lot of fights in between. It was interesting to say that the Dutch finance minister is not only the Dutch finance minister, but the whole Dutch government is now under heavy attack, because on the one hand they are very strong in not allowing the so-called corona bonds to happen, which means that financial solidarity between the European states is lacking quite a lot. And even when it comes to sharing materials and IC beds between the countries, especially the countries in Northern Europe and Southern Europe, you see that there is it's not as it was supposed to be. It's everyone for himself seems to be the question. And then if we try to find out what will happen in Africa, there is also a lot of debate about how to measure or how to model the potential threat. If you look at the left picture, that's an estimation of different countries and the risk they have, but the estimation is based on data that comes from the national level, from governments, from the number of people that live in a country and the strength of the healthcare system, etc. But if you look at the right side, you see where all these people are at this moment who are at risk. The refugees, the people that live in the Sahel, where there are huge numbers of migrants that are stuck on their way to Europe and not allowed to move on, not able to get back. They are sometimes they are in camps, or they do stay in other places, and these people are not counted into those modeling that comes from the national government level. So the question is, who do we focus on? Do we have a universal approach, or do we have a targeted approach? These are difficult questions to answer, and they should be answered by whom? By the governance of the pandemics, but also by the governance of the nation states. You see, there's a lot of things happening throughout Africa. The African CDC in Ethiopia is very active, but also the countries that have already experienced Ebola are taking measures. Just as what Wim said before, in Congo, but also in Guinea, there is a very, very strong feeling of showing the lessons learned from the Ebola crisis that's taking place as we speak. There are activities going on that are sometimes underestimated from our northern view, and they should be taken into account, I think. At the same time, on the left, you see the measures that are taken in a number of African countries, and of course, what the most attention goes to those places where isolation and the blockage of cities causes a lot of trouble, but it doesn't mean that everything is negative. There is a lot happening that should be taken into account. The economy, of course, everybody talks about the economy. The economy is, at one point, is maybe the cause of epidemics. We'll get back to that later on. At the same time, we see that some positive things are that this virus is not like SARS or MERS, also affecting cattle, livestock. It means that the food shortages are less than in other pandemics would be possible. But what you see is that overall the economy takes enormous blows. That means that the global markets are going down, and that will have effects that will also touch the poorest groups of the population. Like always, it's the poorest people that always carry the brunt of these kind of things. The economy is stupid comes back again in what many people say. This is the time to look at a more inclusive economy. The example that is often mentioned is that of the donut economics from Keynes Rayworth, which I think is an interesting model in these times to see how you could avoid let's say, the stress on the planet that might cause pandemics like this, and at the same time ensure that the economic growth or the degrowth or the stability is equally shared among the people in the world. So I think this will have new relevance at this moment. There is, of course, also the link to the environment and the environmentalists. And at the beginning, there was quite a lot of hope that 77,000 Chinese children and elderly would have been saved because the air above Wuhan is much clearer, as you can see on the left picture. At the same time, the same scientists who are looking at this have already revoked that and said, listen, we were too fast. It's now again getting polluted because the economy is started up again. So that means that if you want to change something, then you have to be careful that it won't happen by itself. There is a big chance that things will go back to normal sooner than we think. And in that sense, this possible gain will only be very temporary. The link with the environment, though, is very, very strong. Climate change has many, many effects on health. But one of the most important things is that the loss of biodiversity has an immediate link to the risk of new viruses being spread out. And this is what the SARS coronavirus is a good example. The places where it comes from is what they say the market in Wuhan. Well, you see these same type of markets in many other parts of the world. But more importantly is that a lack of biodiversity makes it easier for the diseases to jump from animals to people and then spread out. So there is a clear link between the environmental discussion and the attempts that we should have to prevent the next outbreak from happening, or at least be better prepared than for this one. This is one of the examples of, this is a market in Congo where all kinds of meat can be, it's very similar to the market that was in Wuhan where the virus came from. Now, there is the last part that I want to mention is about cultural and society effects. These are the official guidelines, the strategic preparedness plan that the WHO has made up for the coronavirus pandemic. And of course, there is the human-to-human transmission, the 1.5 meter distance that everybody is supposed to have. There was already at the beginning a recommendation from the global mental health communities. Why don't you say physical distance instead of social distance? Because social distance has a lot of connotations that people find difficult to deal with. And then, as you all know, social distance is very different if you live in a villa or you live in a slum with a family of 15 in a very small group, a very small space. One of the other ones, very important, is the isolation of people that are tested and are at risk. One of the big problems at this moment is the border between Iran and Afghanistan, where thousands or 10,000s of people are Afghans coming back from Iran, because in Iran the crisis is very high. It means that jobs are stopped and people have no income anymore, so they return home. They also return home because this is the time to harvest, and all these people come from highly endemic areas, but there is no way that they can be tested. So the figures from Afghanistan, where people are trying to prepare, the people of the Ministry of Health are trying to prepare, but they have no data to work on, and they have no materials to even find out what's going on. So that is well, the same situation as you see now in India, where people are trying to get back to their homes, and what you see, or threatens to be the case in South Africa, and what might happen in Kinshasa, where it's not happening yet, but also in Madagascar, you see that there's a whole blockage on national roads that should bring people out of the city back to their homes. And this is where a big group of people are blocked, and that's, well, with all the horrible effects that might come out of this. Then one of the guidelines, which is a very interesting one of the advice is to address the crucial unknowns. But the interesting thing is, we don't hear much about research going on to find out what the unknowns are. And I think that is the type of research that should be starting right now at this moment, because there are all those places, like in the Sahel, like on the frontier between Colombia and Venezuela, where people are at very high risk. We all know that, but we are not, well, at least I haven't heard of much research ongoing to find out what possible response could be thought of in these kind of, let's say, situations that we know very little about. And then finally, the communication is an issue in itself. We talk a lot here about the difference in communication between different countries in Europe, but it becomes even more complex if you talk about communicating this in those countries where many people have different health beliefs and different ideas about the value of communication that comes from the government. There is also, I think, something that we could be prepared for or should be prepared for. In all studies about crisis and what comes out of the crisis, the so-called honeymoon period. And the honeymoon period starts usually between 4 and 8 weeks after the event. When the event happens, and you have to, like what we had here in our country, at about the end of February, then we know that something has to happen. Something has to happen fast. There's a lot of information, and what you also hear, there's a lot of solidarity. We will get through this. We can do it. We should all be together, stand together. In whatever kind of level you talk about, we stand together as a village or as a region or as a province or as a country. But at least there is some level of solidarity that has to do with the fact that the crisis is new. Now, after a while, and we begin to sense that now, yesterday, it was a little bit before that the rules for social distancing and for staying at home are extended with a few weeks. This is now, the time is beginning to come where people are irritated, where people become to get tired of following all these rules and guidelines, and where some people at some point will start revolting. And revolting can be in a very small sense in a village in Germany, can be perhaps in a different way if you talk about a slum in South Africa. And that disillusionment is something that has been seen in every crisis so far. And I think not much has been done yet to see how we could prepare for that. So it's a special thing that we might be thinking about. The cultural response is, of course, everywhere. I had no time to find all the examples, but there's a lot of examples. This is Cambodia. In Cambodia, maybe that's interesting to just say a little bit about. In countries like Congo, like Guinea, in Cambodia, so in many different places of the world, one of the things that people have in common is that a virus is, of course, a threat, and what is said about it from the scientific point of view is taken very seriously. But there's also something else. That is the absolute belief that if people are hit by the virus, then that is not by accident. That is not a statistical given. That has something to do with the behavior of those people or with the spirits or whatever you call it that reacts to that behavior. That means that it's a kind of a double security takes place. People do want to protect against the virus itself. At the same time, there is an urgent need to protect against those spirits that hover around and that might catch you, and those would be the spirits that are driven by the people that have already deceased. You see this very clearly in Cambodia, where on the one hand, nobody disagrees with the official guidelines, but at the same time, people have to protect themselves from the spirit that come with the virus. So also in Guinea and also in Congo, we know already that this is happening. And that's the interesting part is that's a good thing, because as you see here, there's a bit too much text, but in DRC, in Sierra Leone, Liberia, so the countries where there is experience with Ebola, we have learned how to make use of those traditional customs, of those traditional ways of carrying messages, of how to reach the people that do not believe that the government has anything for them that might be good. And there's a lot of those communities there. And you see that religious leaders play a very important role. And they are being sought and they are being used already to pick up the role that they played very well in the Ebola crisis in some parts, to reach out to those people that cannot be reached by government messages. So there's progress. There's absolutely things are getting better. If you look at the culture not so much as a part of the problem, but as a part of as part of the solution instead of the problem, then there are many ways that have been tried already. Where if you do get into the culture, you try to understand what's going on, and you can then, based on mutual respect, you can mobilize people and resources in a way that doesn't work if you only have the international guidelines. So there is a great need for local response, I would say. This is what we have been thinking about here at the Institute of Tropical Medicine, about what interesting and important research areas would be. There is, of course, the healthcare systems. We mentioned that already. There is if you look at the different healthcare systems, as unfortunately Alex would have told us a little bit about the situation in Guinea. There is, of course, experience with the Ebola crisis, but there's also a new center being built, which that wasn't planned for the Corona crisis, of course, but as a result of the Ebola crisis, there is a center of excellence now being built in Conakry that should cover the West African region for transmission of all diseases. So these are responses that have come out of the last crisis, and what we should hope for, and I think what we should work for, is that these responses become stronger and stronger so that the next pandemic can be better controlled. At the same time, if you think about community research, there is a lot to be learned from what's going on now in those places where actually nobody knows so much what to do at this stage. If you think about, let's take the Sahel and you see how many vulnerable people are there, then we know there's no water, there is no soap, there is social distancing, very, very difficult in these refugee settings. But it doesn't mean that there are no solutions to be found on the local level. That takes talking to people, finding out what people themselves can do, and the resilience that you may find or the inventiveness of people, it's sometimes surprising. There is, of course, the epidemiology. That's the most, the first thing that comes to mind if you talk about the pandemic. But there, the biggest need is for data. How do we get reliable data, and how do we evaluate these data, and how do what kind of modeling issues can we have? How are we making use of all this modern technology that's taking place? There is this discussion about how in more authoritarian states people use the digital systems that are also used by security and by armies to find out how people move around and what they do exactly. Like in China and Taiwan, that has been effective. In Israel, it has started already. And this, of course, also calls for, let's say, protective measures in the sense of democracy and privacy of individuals. Then these are very interesting debates that have been going on for a while. And I think that they get an enormous boost from this crisis. Clinical diagnostics and therapeutic research is, of course, absolutely needed, and it's done. I think that starts up very fast because the capacity to do this is widespread. The problem, though, is that still most of that capacity is in countries that are Northern African countries, and that brings me to an issue that is, of course, very interesting. This is one of the first crises that has come to Africa externally, comes from other parts of the world. If you look at the situation, how it's evolved now in the United States, well, there is a lot to say about it, but it's interesting to see that in the countries where most of the well-equipped institutions, research institutions and universities are, those are the countries that are hit hardest. So would that give us any lessons on the relative value of having these centers placed out more in a global scale? That would the CDC, the new Center of Disease Control of Africa in Ethiopia has a good role to play, and maybe it's time for us to switch the poles, as we like to say here at the Institute, and think about how in the next pandemic advice can be sought there instead of having the automatic impulse that we need to advise the other people what to do. I am coming to concluding remarks. I've spoken very fast, I see, so I will want some time. So who knows, there's more time for questions and discussion. There will be a lot of questions and discussion. I think that if one of the things that we may expect is that at some point within a few weeks, this crisis is thought to be under control, the normal world takes back over, and then things will be as they used to be, which is not bad in a sense, because many people need that for secure living circumstances, etc. At the same time, there is now well, you know, all the typical Chinese character for crisis is the combination of danger and opportunity. I thought there would be no better way to conclude this short presentation than pointing at all the opportunities in this crisis. And that is my presentation. Thank you.
So thank you very much for the presentation, which was a bit shorter than expected, but very well structured. Thank you for this. We have a number of questions, among which some are also rather of a medical kind. So I think that, but we also have Marcelin Widowson, if all goes well, among us. Marcelin.
Not yet with us, but he will be coming shortly after 5.
Okay.
So,
okay. So perhaps we treat the other questions first, and then perhaps we can involve Marcelin Widowson a bit later on. So yes, let's go to first question, Willem. One person asks how to cope with fear of well, people fearing coming to hospital even. How could we cope with this?
There are kind of new guidelines. The ones that I showed from the international the agency in Geneva has a lot of guidelines on how to respond to this. There is in Italy, very interesting, there is a network of more than 9,000 psychologists that have combined forces, where people family members, but also family doctors, they can reach out to this network to find advice on how to deal with fear. There is a lot of fear going around, and especially the isolation or the people that have to stay at home and live on their own and have quite unstable situations already. Of course, they have the most to suffer from. But at the same time, there is a lot of material around, and you will be able to find some of that in some of the slides in the links on how to respond to it, and also to find professional networks on where this is a cause of concern. Interestingly enough, if you look at the cultural differences, then the picture of the monks in Cambodia that were last week on Thursday praying all together was actually a community response to deal with the fear that the population has on what's going on.
Mm-hmm. Yeah. Okay. Perhaps one of the remarkable things in your presentation, as I see it or as I understand it, is this that you say that probably we're going to go back to normal more rapidly than we might expect at this moment. But back to normal, I guess, might involve different stages or different dimensions. Perhaps it's back to normal in the sense that we will not be in lockdown situations anymore. But then, yeah, there are perhaps some other aspects where perhaps change would be a bit more permanent even.
Yeah, well, for those people that like football, I think back to normal, having a football match is a very positive thing. But on a more complex scale, back to normal in terms of reinstalling the machinery that makes the air pollution come back to the levels of before is something that we should be concerned about, I think. That is let's say it's a window of opportunity to talk about these things. And I think the biggest danger is that those people that want that change now jump on this crisis and say, now everything has to be different. And then you will get into a kind of a political discussion that won't be very fruitful. Now is the time to try to reach out to each other and find a kind of a middle way to at least make some things change. And one of the things that I think, well, the lesson learned from this pandemic is that we would really have to do something about the global architecture of the health system. At this moment, if the Secretary General of WHO, Tedros, if he says now it is a pandemic and now everybody should do more or less as he thinks best, that is not very helpful. But basically that was what the message was about. There were no strict guidelines on a national level, which means that all the nations started doing what they would like themselves. On the European level, there is in Sweden, there is a European Center for Disease Control, which has no means, no power, nothing. So these, I think, are lessons to be learned so that we do not go back to normal in that sense, that there are some improvements and some lessons learned that are turned into practical changes.
Mm-hmm. Okay. Now let's go a bit into the management of the current pandemic. at the national level in the south. There's someone who asks about one of the remarks made by Wim van Damme on the lessons learned from Ebola. And one of these lessons was that we shouldn't constitute parallel systems to cure this virus, but rather try to strengthen the existing system. Now, how is this going to happen? How can we understand this? Could you expand a bit?
One of the things that happened in the Ebola crisis, but also in crises that are more political of nature and not by virus, is that with all the NGO input, all the civil society reactions to a certain crisis tends to set up a system that becomes a parallel system to what the government is supposed to do. And that, of course, is very different from one country to the other. In a country like Rwanda, for example, the government has become quite strong and will not allow this to happen. Whereas, take the other extreme in Afghanistan, what I hear from my friends there is that the Taliban-controlled centers are more effective now in dealing with the pandemic than the national government is. And that is also a parallel system. So it depends quite a lot on which situation you talk about. But overall, the idea is that if you want to deal with a pandemic like this, there should be one system to make it more effective. And I think Europe proves it, that the European countries do not share one system to respond to it, which creates a lot of confusion. I myself have family members in France, in Holland, and in Belgium, and we all three have different messages on what we should do and should not do, which is not helpful. So in that sense, coming to one common approach, which means one system, is, I think, the way to go.
Okay. So, okay, another question from the Philippines. I saw that in the Philippines they are advocating for mass testing. I'm wondering if that is achievable because there is a shortage of tests and if that is really needed as well.
Yeah, that is, I'm not a specialist on that field, but what I hear is that mass testing has been the success in Taiwan. Mass testing gives you the data and the information that you need to take measures that are targeted at what the best effect would be. And this, the question of having the tests available is one thing, but you have different types of tests and you have different types of machinery to use the tests, or the machinery that you need to analyze the test. These are questions and issues, I think, that need governance to improve that for the next pandemic, because that is the biggest fear. It will happen again, and then those tests should be easily made available. It's one of the biggest issues. The last 2 weeks ago, I was 3 weeks in the United States, and people told me that President Trump will lose the elections not because of the Democratic Party, but because of the fact that he has economized on the CDC in Atlanta, taking away their testing capacity, taking away the possibilities they have to develop new tests, and that the next step was that there was a fight between the private sector and the public sector about this. So the testing in itself, I think that all virologists, all epidemiologists agree that testing is key, and everybody's trying to do the best he can with the limited means that they have. And those means are limited between Italy, France, Holland, and Belgium, and even much more so in the south, of course. But I think this is one of the biggest challenges, to bring about some kind of global scheme that would at least agree on what tests where should be produced and distributed in an equal way.
Okay. Related to this, there's a question also on the reliability of the data on people being infected, because this apparently the data are sometimes switching quite spectacularly as well. Like I think yesterday Japan was a sudden upsurge, which is, I think, medically difficult to explain. There's also differences even within Belgium, different provinces reporting in a different pace. Could you explain a bit how could we improve on this, perhaps also in the short term or the medium term?
Yeah, I think the same answer applies. It would be preparedness in the sense of knowing which test you need. Like there's a lot of discussion in Holland, at least now, about on the one hand the test to find out if somebody has the virus, and on the other hand the test for people that have had the virus and have recovered to find out whether they have now developed some level of immunity. And those tests, I think, are equally important to find out what is the best way forward to take decisions at the governmental level on what measures to impose on the public. So the different types of tests, the different levels of how many people can you test. There is examples from different countries, but also, as you say, it's one of the interesting things of this pandemic is that it's like an equal playing ground between the countries in the south and in the north. Because in the north we are making at least exactly the same mistakes and have made the same. We have not been able to prepare for this in a way that we would have been able to, given the resources that we have. So the choices that have been made in where do you spend your money, or what do you take as serious warning, these are the lessons to be learned.
Okay. One question on ITM itself, the Institute of Tropical Medicine. How does it see the future in managing or dealing with corona in terms of, I guess, both policy and research? Do you have an idea?
That's wonderful. Then I can answer that question just a few minutes before the director comes, and then see if we agree on it. But. Yes, but we are talking a lot about what our research priorities would be, and the last list, the short list that I showed you, one of the last slides, is the present state of affairs. Is that we try to take all the three different parts equally. You know, the one is, of course, who can help to develop a vaccine, who can help to improve treatment protocols, and who can help to increase the protection of populations in the south. And given that the Institute of Tropical Medicine, its mandate is basically about those countries in the south that lack the means that we have, the primary focus is on those situations.
Mm-hmm. Okay, a question, an economic question, or perhaps a more general question on how long can this situation we are currently living, how long can it last? But mainly economically speaking, but also in terms of provision of water, provision of different types of resources. How long can we survive in a way?
That's a wonderful question. It makes me think of when I was at the presentation of Yuval Harari, you know, the Israeli historian. He said everybody thinks that if you say some words that you're a prophet. The thing that what you see clearly now is that if in those circumstances in the south, in those big, that's what I think the real horror view of a pandemic, situations like those at the railway station in New Delhi, those people that go home, and when they go home they have no money. They have no money to buy soap. There is no water available that's clean enough to clean yourself with. You have to share your food and everything that comes with your daily living with a large group of people. There is no way to isolate yourself from those people at risk. I mean, how long will people survive? The horrible thing from an epidemiology point of view is that we will learn that lesson in a few weeks' time. But it doesn't look good. I think that if you look at the situation here, then as people say, well, compared to the time that grandparents were called to war, this call to stay at home is quite modest. We should be able to survive that. There is no shortage here of food. I think that's a big difference indeed, as was said, with other viruses that also attack livestock. There's more than enough here. We can stand it. We can survive, even though flattening the curve, that is the word that is used all the time. So making sure that the number of people that need help does not exceed the capacity of the health system. That's what we're trying to do. So we spread out the pain, so to speak. That helps, and it is effective so far, but we still don't know what the end outcome will be. Some people have hope. Some people say this virus, the disease, the COVID-19 disease is relatively mild as compared to other diseases, but we do not know enough yet on how that will affect people that are already vulnerable There is something known about the fact that there is a big correlation with people that have tuberculosis or any other kind of lung disease. They are much more vulnerable, and for them, the virus will be much more of a killer disease than for people that are perfectly healthy.
Okay. Coming back to Yuval Harari. You hear me well, Willem?
I hear you. I see that Mark Alain has joined us
okay.
from the desert. Wonderful.
Hi.
Okay, so coming back to Yuval Harari, one of the things he's pointing at is this, or one of the contradictions or the paradoxes he's pointing at for this virus is it's that's a global virus, but it's managed nationally, predominantly nationally. But then this means also that it will be difficult to manage this virus also in the later stages, because it will survive, I suppose, in different regions of the world in different time periods, and so the world will keep continuing to be affected and infected in different countries. So how shall we manage this? I suppose we should start from thinking that this will basically be national systems who will manage, but then they will have to harmonize their systems among each other.
That is what we hope they will do. That's what I think common sense tells us to do. But then, of course, this is up to the politicians, I guess.
Yeah. But how do you see this more specifically, this type of harmonization? How could it work?
Well, there are some examples. Many people don't even want to think about it again, but there used to be this initiative of the WHO on health for peace. And there was this one example in South Sudan where the warring parties, where they were convinced that it would be good to stop fighting for 3 months, so as a vaccination campaign could take care of all the children of all the warring parties. And that worked, and those 3 months were used for the parties to come together in Addis and start negotiations about a peace process. Well, something similar might perhaps be happening here, is that if this crisis is seen as a pandemic that is global, then why not take this opportunity and do something, let's say, out of the box, and start talking on this governance level to see how we change the structure of global health. I'm an optimist now. Huh?
So let me ask some of the questions we kept really for medical doctors. One is the possible interactions, but also differences between the coronavirus or COVID-19 and ordinary flu.
So just to clarify, I'm not a medical doctor. I'm actually a veterinarian. But
okay.
but I have worked on influenza for the last 10 years. I can talk a little bit about it, but not without claiming any specific clinical expertise. On a clinical side, in terms of medical presentation, I think one of the similarities, of course, is that influenza infects older people, and people with comorbidities are more likely to die. And the older you are, the more likely you are to die of influenza. That's where the large mortality is, and we're seeing that with COVID. So that's very similar. What is not so similar is that we don't seem to see any clinical illness in young children, whereas influenza does cause clinical illness, quite a lot of clinical illness and hospitalizations in young children. So that's one clinical difference, I think, between the two. The second difference is that influenza often causes its greatest harm through a variety of mechanisms, by setting the body up for a secondary bacterial infection. And then when I say influenza, I mean seasonal influenza here. And so there are a variety of different reasons why this could be, but often we find at 2 weeks, when you do the modeling epidemiologically, you find that after 2 weeks after an influenza peak is when you get the mortality peak. And that's often because this secondary bacterial comes in. For COVID, we are seeing secondary bacterial infections, but that's not the real issue. The real issue is acute respiratory distress syndrome, which is basically when the lungs fill up with fluid. And that's essentially a viral problem. So that does have a management issue in the sense that influenza mortality can to some extent perhaps be prevented by antibiotics, which I would say relatively available around the world. But the problem with COVID is that severe disease is not generally caused by bacterial infections, therefore not treatable by antibiotics so easily. And what we see is, of course, that you need ventilators to do this properly. And that, I think, is a particular problem for low and middle income countries, is to find that those ventilators is what you need to treat the disease.
Okay. Thank you. Another question was on the difference between SARS, MERS, and COVID.
So, are the questions related just to clinical or just in general?
Yeah, I think just in general. In general,
okay. So obviously SARS and MERS are both beta coronaviruses, so they belong to the same group of coronaviruses as COVID-19 or SARS-CoV-2. Much more mortality, 30%, 40% for MERS and SARS, whereas we're seeing 2-3% for COVID-19. So or SARS-CoV-2. So that's one fundamental difference. But this virus also seems to be much more transmissible and seems to also have a higher affinity for upper respiratory tract receptors, which means that it seems to transmit more easily than we're used to seeing with MERS and SARS, which essentially MERS transmits to one generation, maybe two generations of people, like novel influenza virus does, like H5 does. SARS also transmitted in a nosocomial. In hospitals, it transmitted widely, but in the community, not so much, and therefore was relatively easily controllable. Whereas this is more transmissible, and that's why it makes it so dangerous. It's more transmissible than SARS, but more fatal than flu.
Okay. Thank you for this. Perhaps going back to Willem, there are a number of reactions on one of the arguments you made, Willem, about perhaps not using or misusing this period to rethink a lot of ways of a lot of the ways in which we are living. Some of the reactions point to the fact that we should use this crisis as an opportunity to change, and for example, to go towards a more sustainable ways of living. But there are also other reactions who see that some countries seem to make misuse of this crisis also to install a more authoritarian type of regime. So that's the question, or there's a number of questions on democracy. Is democracy in danger because of what we are seeing right now? And here there is, the examples mentioned are Hungary, Honduras, Kenya.
Yeah, there's people that write about it, and I can understand those concerns. And that is a real risk, of course. There is, like always, never waste a good crisis. And everybody has that thought. So populist politicians would also take this crisis to say that a lockdown and closing the borders would be the best for the country that would happen. But the thing is that kind of political discussion is taking place, and it's interesting to see how this debate evolves between, on the one hand, the proven effectiveness of using the big data and the algorithms that go with it, and at the same time, the question who should control that use of the big data. That is a test for democracy. That is, I guess, for the countries that call themselves democracies, a bigger test than for countries that do not feel that they need to defend democracy so much. Which is, it's an issue, I think, like in China, Taiwan, where these data could be used and are at the disposal of the government. Then, of course, your reaction can be much faster and much more effective than in those countries where you have to reach a certain consensus. But that is the same thing. I think it's one of the elements of democracy that you can't get away with. It's like what Churchill said when he was asked, why don't we sell all the jewelry and the crown and the museum so we can make more weapons to beat the Germans? And his answer was, well, what are we fighting this war for? So in a sense, there's always a balance between the values of how you live together and the threat that comes from a virus like this.
Okay, thank you, Willem. Another question on the future as we see. Well, perhaps that's a question rather by someone from Europe. So we are now in lockdown period. So let's suppose this lockdown will be lifted by the end of April or even May. But then, what can we expect for the months after this? Will this be the new future be interrupted again by other types of lockdown or social distancing measures? Can we expect that?
I can go.
Willem or Marc-Alain?
Yeah, I can give a crack. I'm a strong believer, though of course I may be wrong, and I accept that this is a seasonal, that temperature will, or climate at least, will fundamentally affect this virus in the short term. So I think that most of the Northern Hemisphere will see a drop in incidence come the hotter months. It won't drop as quickly as influenza, I don't think, because influenza, there is a lot of immunity to influenza in the community. So as the hotter weather starts, it gets more and more difficult to overcome the hot weather, because it's and the fact that there is an immunity. This virus is still, I think, still many people, and people differ on how many people are infected now, but most people, I think, at this stage are still non-immune or susceptible. So even as it gets hotter, I think the virus will still find susceptible, will still find dry wood, if you will, to continue to burn, even though it gets hotter. But I think eventually the climate will win out. And this is what we saw with the swine flu in 2009. It'll go at least down, probably not disappear, but go down. And then, of course, we're in a situation where we have a lot of susceptibles still in Europe, and then it will come back in the winter. I think that the tropical seasonality is more complicated. And there, I think that if you look at, again, my only reference point is influenza, but influenza circulates throughout the year. Erratically, you get seasonal peaks here, there, and everywhere. So I think that, and this is a problem for tropical countries, is that we think of a lockdown, we think of May, June, and then it'll be okay, at least for a few months. We can prepare, we can take a breath, we can take a breath, we can then prepare for the next winter, buy ventilators, get beds, you know, mentally prepare ourselves for more lockdown. But for tropical countries, and I say tropical meaning literally in between the tropics, a tropic of Cancer and a tropic of Capricorn, there the seasonality is not so clear. So it's much more difficult. When India locks down its country, you know, they don't have such a strong seasonality. So how long are they going to do it for? I mean, it's a real problem. And I wrote this article in the newspaper here, the Knack, what's my train of thought? I forgot what I was going to say, but it's a problem to lock down for a long period of time, and to maintain these measures, which are quite draconian, particularly in tropical countries.
Okay, but perhaps it's also the only scenario, realistic scenario for these countries, taking into account the situation of the health system.
Yeah, no, it is, and I think, but I think countries are looking at it creatively, or at least there are dangers, I think, about applying lockdown in a similar manner. So just two examples. In India, some of you may have seen that the lockdown has caused this tremendous internal migration. You've got a lot of people, the poorer communities, rural communities who work in the cities are now taking to the road, and they have to walk 300, 400 kilometers to get home. And there's no transport, of course. So, and these people who have very little food, and so you are creating in many ways another crisis. So I think that when you have a country which doesn't have government support for most of the people, and most people, many people live from day to day, then it becomes very problematic to think how to implement it. For us, it's easy. We have Amazon. We can, do all sorts of things. We have a government subsidy if we're unemployed. But as we all know, this is not the case in many countries.
So you're suggesting, in fact, that the lockdown scenario is not a realistic scenario in the tropics.
Yeah, I hate to give advice because I think realistically, and this point has been made before, is that when we think about these measures which affect our lives so fundamentally, that really what's needed is a diverse group of people to give opinion, I think. Because it's an ethical issue as much as it is an epidemiologic issue. And we can hear about saying, well, lockdown will flatten the curve, will not flatten the curve. But clearly, it's a far, far more complex a situation than that. So it may be that in India, when you get the diverse voices together and opinion, you say, well, no, we're just going to weather it out. We're going to accept that some of the elderly are going to die. I mean, maybe that will be the decision in India, because we've decided, we've balanced, we've looked at everything, we've come to a different conclusion, and our reality is different, and our consensus is different. So I don't know what the answer is by any means, whether a lockdown is a good idea or not a good idea. But because it's such a broad and affects our lives so fundamentally, that it has to be a consensus decision, which may differ from place to place.
I think this is exactly why we need some of the social scientists to help us out, because if you could sketch something like a real horror scenario, then what I was saying before about the honeymoon phase, which is now almost beginning to come to an end here in our Western luxury lockdown situations. If you think of all the people on the roads, as Mark was saying, it is very good. There is a possibility that when these things explode at some point, when people can't stand it any longer, then what you very often see in crisis is a scapegoating mechanism, is that some people need to find a guilty party or a guilty group. What you have, before you know it, you end up in violence, in ethnic strife, and all those kind of things. So the only thing that you can think of is communicating, and this is bringing the message around, making sure and listening to what people themselves have as solutions, like group isolation, like how to communicate between groups that it's better to stay apart. I mean, there's lots of things that you can think of, but then you have to actually be there, talk to the populations, and think together with them what the solution might be. So communication and the different parties that can communicate, so not only the government to the people, but also the traditional leaders, whoever the community leaders. There is, as I have seen in some countries where I worked, if you are sitting in the middle of an Afghan village and the whole world tells you that everything is impossible, then in no time you can stamp out a group of active women who take the lead in that village. It's all possible as long as you communicate with people at the local level, and I think that's what we need now to prevent those horror scenarios.
Okay. I have another question a bit related to this. So self-isolation doesn't only help against corona. It might also help against other types of diseases or viruses. Someone asking from Mayotte asking this question about, well, because apparently in Mayotte it's combined with dengue and leptospira outbreaks. So I suppose there's no interaction between these three types of outbreak, but perhaps there is an interaction in terms of the policies against them. So the question this person asks is whether, well, what should we choose? What kind of strategy should we choose? It's rather protection, self-isolation, or rather testing and tracing.
Well, if you ask me, the self-isolation, I think, works fantastically against narcissism, and some political leaders could perhaps use that. I give Mark the more serious answer.
I'm not sure I have a more serious answer. I didn't fully understand the question. Is that looking at these other, whether the measures that we're taking against COVID are having an effect on these other diseases as well? Is that?
Yeah, exactly.
Yeah. I think plausibly they should. I mean, and I think there's some evidence looking at influenza, for instance, again, that the rates of influenza are dropping faster than they'd normally be expected to in certain countries. So yes, I think we would expect any person-to-person transmission disease to reduce, and maybe that's going to be that could counterbalance some of the morbidity we're seeing in COVID-19.
Mm-hmm.
Certainly also seeing, I think somebody mentioned that there's some data showing that, of course, traffic accidents have gone down, and mortality due to these other things that we accept as our day-to-day mortality risk, those have dropped as well, which is an interesting, then it does become a whole ethical thing, is that, and there's some debate in the United States about this, well, don't people die normally anyway? Isn't this just part of our normal death? And shouldn't we just accept that living is dying, and you know, we don't stop driving cars because we know they're going to kill us, so shouldn't we just carry on with COVID knowing it's going to kill us? So there's some of that that's going on.
Okay. Another question on the way in which the virus developed. Can we see, perhaps it's a bit too early, but can we see some patterns between types of regimes, like democracies or more authoritarian regimes, and the way in which the virus has developed or been allowed to develop?
Well, when I was looking for cultural response, I also found an article that I found quite interesting about the cultural response in the United States, where they said that we have a government that hasn't helped us very much. What we now need to do is to find our own local resilience, and then there are all kinds of examples from the history of the United States, is where, and I think it's true, that is a country where in an enormous quick time, a lot of things can happen and can actually change. And you see that, I think you can see that happening here too. It has taken a long time for all these headstrong Northern Europeans to accept that the government would tell them to stay at home. But now the message has come clear, and you see that attitudes are changing. This is also one of the side effects of these kind of measures, that people reflect. Isolation is also very good for self-reflection. People begin to reflect on what their attitude is towards these kind of crises. And I wouldn't be surprised if in the United States some remarkable community initiatives would come forward that we wouldn't have thought of before. So in that sense, I am quite optimistic that something will happen. The same thing, of course, will also happen in those countries with limited means and low incomes. And there you can only hope and that this will be benevolent, and that it will not be at the expense of some minority groups or people who will be the scapegoats there. And that's what I mean with at this moment, as you see in most of the communication experts, communication should be completely open. The experiences should be shared internationally and also between the richer and the poorer countries, because there are similarities there that people will recognize.
Okay. A question on the architecture of the public health infrastructure. We are now betting, well, at least in European countries, we are betting on intensive care systems a lot. Isn't there a way to try and redistribute the division of labor within the public health system and try to give a bit more emphasis on ways in which the first line can help better, can be mobilized better?
If you look at it from a medical anthropological point of view, you look at the differences between the ideas about health and illness in the European countries, then that helps to explain why there is such an enormous difference between, let's say, Germany and Holland, where in Germany there's more than 10 times as many IC beds per head of the population. That also has to do with the attitude towards an illness, whether you attack the illness or the person. It has to do with economics, with how you economize on health, but it also shows, I think, a question that is a very, very difficult ethical question. At what age do you begin to talk with people? Do you really want to have an IC bed? I know that in Holland that has been an attitude for quite some long time, where many people then say, well, I'm 85, given what an IC situation would do to me, I prefer not to go there. But in some countries, you don't have that discussion because it's an unethical question. And these are differences that have to do with the resources that are available. So in this crisis, we might perhaps also have that type of discussion and see whether we could not come to more common ground so that it's easier to share the resources we have. Because, of course, it makes it difficult for a country to say, okay, you have economized, so why should we share our beds with you? You know, if we need to go a step back and see whether our ideas about what good care is, whether they could be more brought on one line. But Mark, perhaps you know more about this, I think.
Okay, thank you for this. But yeah, so I think the question was rather on the supply side rather than the demand side, huh? Whether it's technically or there is, yeah, we could expect some innovation or something to kind of redistribute the most of the work in treating corona patients from intensive care to first line organizations.
Well, it's a great idea. Tough to see how you might do that because of the specialist nature of the care that's needed, I think, for severe cases. So I think good idea, and I think some of that's, I mean, you have some decentralization of capacity. I think it's worth countries, when we're thinking about next winter, I think there is some thought that needs to be given, if it is going to come back, which again, it may not, but I think it probably will, how we can decentralize capacity of ICU beds and build it not just in hospitals, but perhaps decentralize it into smaller specialist groups and to simplify some of the protocols, possibly, so that you can do maybe some intensive care outside of hospitals and keep hospitals just for the very, very severe cases. So there may be some thinking into this in Belgium and Europe come the winter.
Mm-hmm.
I know that in Holland there are some hotels are preparing beds now for people that cannot, there's no place for them in hospitals. There is talk about a kind of upgrading training for nurses that could help people who should be in the intensive care but can't be. So people are preparing and thinking of different ways how to respond to this.
Okay, and another medical question. Once a patient has recovered from COVID, is this patient immune to the virus?
$1 million question. Don't know. I think immediately, yes, likely. If you look at antibody levels in SARS, and they last 2 or 3 years, then they go down. For novel viruses, our bodies tend to not produce very sustainable antibody responses because we've never seen anything like it before. So we make an antibody response, but it's not boosting something which is similar. So we often get quite a drop in antibody levels. We see the same again for avian flu, for H5N1, for instance, is a big antibody, but then it drops quite quickly. Unfortunately, coronaviruses in general don't seem to have a very good immune response. So if you look at the common cold, there are 4 coronaviruses which cause the common cold and upper respiratory tract infections. It seems that the immunity to those is not great. That's why we get colds throughout our life. And so I think that the easy answer to the question is if you get it, I suspect you're immune for a bit, but whether you've got lifelong immunity, I don't think is known.
Okay. Thank you. There's a question. Well, I'm not sure whether it's a question. It's by a remark made by someone from calling in from Beijing, China, and saying that, well, apparently now, after some months of hard work, everything is back to normal in China. What can we conclude from this? Did this work? Did the lockdown did it do its work, and is it something necessary to do?
I think that it was an amazing success, really. I mean, the fact that it's back to normal, I mean, it's something that we can't, here in Europe and the US, even envisage being back to normal quite yet, maybe in a few months. I think that the lockdown and our Chinese colleagues will know better, but the lockdown had, of course, a big effect. But there's also, as we're seeing in many other countries, the importance of testing and tracing cases. And in China, for good or for bad, there's a lot of face recognition technology. And from what I understand, if in Wuhan you went to buy some bread and you went to a baker and then you tested positive, then actually that test would be related to you as an individual. You'd know where you were, and the baker would be notified that they had contact with a case that was positive for that bought bread from their shop that was positive for coronavirus. So that then allowed the baker then to do something. So it was more than just a lockdown. I think it was combined with testing and tracing, which made the difference. And we're seeing that also in Korea, for instance, in South Korea, they did a lot of testing and a lot of tracing and that really is what made the difference there. Okay,
so it requires really an approach that is flexible enough also and to change over time. In fact, there is also a debate going on in the chat part. I think we asked to ask questions in the Q&A, but there's also the chat going on, and there's a debate on the importance of climate and weather. Some of them say that, well, stating that there is this influence of the weather is giving people false hope. And of course, there would be a lot of need for hope in any case in tropical countries, but false hope would not be very warranted. But can you comment perhaps a bit or expand a bit more on the relationship between temperature and the spread of the disease?
So on Medrivix, if I pronounce that right, which is the preprint website for papers which are not yet made into publication, I looked at this yesterday. There are 3 or 4 publications on looking at temperature and the incidence of COVID-19 or SARS coronavirus 2, and it does, looking at modeling, does look as if the cooler it is, the more transmission there is. There's also some data from SARS, which ended roughly in about July of 2003 or 4, that it was before the summer. So there's some evidence that temperature has an effect. But 2 things, I think. Seasonality is not just temperature. It's humidity, it's perhaps host factors, it's all sorts of things. It's one of the big mysteries as to why we get seasonal flu anyway. It's not crowding. I do the same thing in the winter as I do in the summer. I don't crowd with my family in one room in the winter. We have central heating. So I don't think we do things very differently in the winter. So so we don't know what causes ups and downs, and I wouldn't focus just on temperature. If we look at the Australian data at the moment, they have testing almost as much as South Korea and haven't seen much transmission. Most of their cases are reported cases. They don't have many local transmission cases, and they are just in the end part of their summer. So that gives me some evidence that warmer weathers are likely to, or at least seasonality is going to affect things. But I agree. I don't think anybody knows. I think we can just try to project the best we can.
Okay. Another medical question. Do we already have an idea on the degree of pulmonary recovery after weeks of being hooked up to a ventilator? Mortality is important, but I am worried about the debilitating post-treatment morbidity and diminished lung capacity as well.
Yeah, I think that there's going to be a lot of work that's going to be needed to understand the true morbidity of this. I mean, we see this for increasingly with diseases like Ebola, for instance. We thought that once you recover, you're fine. But actually there's a lot of long-term damage, neurological damage, as well as other damage to the body. So I think looking at lung function, over a period of years after infection will be important. But I don't think there's any data on that yet.
Okay. Yeah, well, I guess there's a lot of questions popping up about which we don't know yet. And it would be, I suppose we need a bit of more distance through time in order to come to a clearer picture of what really happened, what we are in. I would like to end perhaps with some questions about the future. First, there's a question on health systems and how the panelists think health systems will change because of this virus, because we are going through this this pandemic. And a second question, perhaps I can ask them the two together, is on with how should we prepare for the future, supposing there are perhaps new or other or new pandemics like this one coming up in the near future.
I think what we know, well, the future is a little bit difficult. We know almost everything here at the Institute. The future is the last thing that we cover. But we know that there will be new pandemics. I think that the proof that this will happen again and that there might be other viruses coming up, that is a certainty. So in that sense, I would expect, and I think we all have a part to play in that the global warning system and the global preparedness system has to change in order to be more flexible, to respond faster and in a more united way than to this one. How that will happen is, of course, is not clear, but I think everyone, if we are true to the democratic values that we believe, that we should all take our part and try to change it for the better. And so there's not an easy solution and it won't come top down, but I think we have to think about how to improve these things. It's a very vague answer, of course, about as vague as the future is.
Yes, and on the first question, Willem?
Oh, sorry, what was the first question there? I lost it.
Yeah, on whether health systems or the health system architecture.
The architecture of the health system. Yeah, well, it's a long debate already about the global architecture. There is I've once seen a map where all the different players were in a kind of a mind map brought together. It was unbelievably complex. There is so much happening there, and there is so much power invested in some of the, look at the influence of the Bill Gates, the Bill and Melinda Gates Foundation. That's enormous. And so are they more powerful than the World Health Organization? Perhaps in some senses of the world, yes. But on the other hand, governance, power, funds and all those things, it's all in one big mix. And it has to be, it would be helpful if it becomes more clear. And I think that what we would like to have is also a kind of a control mechanism from democratic governance principles, that the decisions that are taken with all that power can also be checked by the populations that have to undergo them. But of course, that's all quite obvious. The thing is, though, that the world is a very complex place to be, and it's not equally divided. So that's where we have to work on.
Okay, thank you for your answer, Markela.
I would just add quickly about pandemics. I think that the really bad pandemics are very transmissible, and I think it's the idea that we can detect them and squish them anywhere in the world and completely eliminate them immediately when they pop their head, I think frankly is unrealistic. There are some which possibly we can, ones are not so transmissible, but then we have more time. But things like this, yes, there was perhaps a delay that the Chinese perhaps didn't possibly report as quickly as they could have. For H7N9 in 2012 and 13, when it appeared, within a week they found it, they diagnosed it, they sequenced it, and they told China had told the world about it. So this was still within a few weeks of a disease which was completely unknown. So I think what's really important, I mean, we have to look at early detection, of course. We have to have good surveillance systems to detect new things. But what's more important, and what we're living now, is we've got to get data on places like Africa. At the moment, we're going blind. We don't actually know the amount of disease there is in Africa at the moment. We don't. We got a drop of a small proportion of tests that have been sent to Africa when you consider the population of 1.2, 1.3 billion people. The number of tests is far less in South Korea. So we don't know where it is in Africa. And how can African nations be expected to marshal and to use the small resources that realistically they have, when they're going blind. So it's even more acute for a country in Africa which can't do lockdown, can't do all these things that we've discussed, and on top of that doesn't even have the data to know what to do. So it's a double complication for many countries. And I think that we really need to focus on shifting, even real time, even now, is getting testing, flooding the continent with tests and flooding them with PCR machines, and doing much more testing and seroprevalence studies and helping to understand where it is so that we can actually do a better job at controlling it.
Okay, but
if I may add to that, I think that's perfectly right. That is what needs to be done in order to know what's going on. At this moment, we don't know. But there's another, what I find an interesting aspect is also that we here in the West seem to have forgotten that sometimes fate is just there, you know, that you can't control everything. And interestingly enough, over the last few years, there's quite a lot of debate with very famous Belgian psychiatrists and psychologists who talk about the endless pressure and stress that the world is giving us, and that leads to all new kind of problems that they find hard to deal with, especially with younger people. And I found it very interesting, as I said before, that encephalitis lethargica, that was in the 1920s, that there was no cause for it. They have found all kind of, tried to find the cause, but the cause wasn't there. So the assumption is that it had something to do with the long-lasting after effects of a pandemic that has created a lot of unrest, fear, and change. And I think that is what's going on here too. And I'm sure that debate will also come up, is how do we deal with insecurity? Because in the end, I completely agree that it would be fantastic if we have as many tests as possible, because then we know, and if you don't know, then there's nothing you can say. But while we don't know, we should also perhaps try to accept that there are some things that we will never know. And this is a discussion, I think, that will come up, and I find it an interesting one.
Okay. Well, one could even add another element, I guess, is that, of course, this which has been mentioned in social science literature on pressure we have put on nature and the environment, and this brings us into a much more risky environment concerning the outbreak of pandemics. So that's perhaps another aspect to think about or to consider when we're thinking about anticipating the next pandemic.
It was interesting to see that you need something much, much, much smaller than Greta Thunberg to change things.
Okay, thank you, Willem, for this final remark. I would propose to end the seminar. Thank you very much, Willem van der Put, for presenting the big picture, in fact, rather from social science perhaps, but then also thank you very much, Mark-Alain Widowson, to bring in the epidemiological aspects of the pandemic. Thanks also to Wim van Damme, if he can hear us from Kinshasa, or Alex Delamoux, who did this picture, but this film, but we didn't see it. We will see it, I guess, through the YouTube channel of Institute of Tropical Medicine. Thanks a lot, all the participants as well, and have a good morning or evening.
Thank you, everyone. Bye-bye.
Now the second part on the challenges. Well, obviously Congo is a huge country, and testing for the disease is done only in one laboratory in Kinshasa. So it's not at all clear what is happening in remoter areas. Kinshasa is a huge city with more than 10 million people, and so measures like staying at home and social distancing and frequent hand washing are extremely difficult in urban slums, which are very, very crowded. Also contact tracing, that sounds very nice, but in practice it's very difficult. across such a huge city, and especially when the case is VIP, and especially when this person died, then it becomes very difficult to trace the contact, and the relatives are often very upset that they are disturbed by the health staff. It's quasi impossible. There have been quite a lot of difficulties to find enough tests. This has now been solved, but as you know, the whole world needs tests now, and there is really a scramble for these tests going on. The supply for personal protective equipment for the frontline workers has not been a problem. There were still important stocks here in Congo for the Ebola response in the east of the country. They have been transported, or part of it, to Kinshasa. But of course, in a huge country and in a huge city, logistics is a big problem. It's always there is no car, we need more cars, who will pay the drivers, the per diems, so the classic practical issues. Another big concern is if the number of cases would increase, are the hospitals prepared for this? There is a lot of talk about ventilators. There are for the whole city of Kinshasa only some 50, and it's not sure they are all very operational. Maybe more important even than ventilators is oxygen. Oxygen supply is quite limited, and that is really the most important medicine, in fact, to treat people with corona. So I was involved in efforts to create additional oxygen production capacity, and the Belgian cooperation will probably flying production unit, containerized production unit with necessary oxygen bottles and supplies to produce much more oxygen for medical use as is available for the time being. Then there is a lot of talk, of course, about chloroquine. And this was previously very, very widely used here, but is now not available anymore. But really, people would like to give it to all the patients, and maybe also as a prophylactic to the frontline workers, but is not available. Then another issue is that initial declaration of the president said that all the corona patients would be cared for free. Now, a lot of people say nothing is free here, and how this will be materialized is not at all clear. It's easy to declare free, but who pays what then? So that was my second part, just overview of a few of the challenges the response is facing here in Kinshasa. Hello, and now a third part on some reflections. So there is a lot of anticipation that what will happen here in Kinshasa will be like in Wuhan or in New York or in North Italy. Now, I don't think that is certain. It's uncertain, we don't know. There are quite some issues that are different here. So it's a tropical climate, while all the big epidemics for the moment are in temperate climates, where the virus spreads more easily than in tropical climates. On the other hand, the city here, Kinshasa, is much, much more overcrowded than any of the European, Asian, or American cities that have been struck by a huge epidemic now. The third is that the population structure is very, very different, with far fewer elderly and many more children who rarely ever do the disease, although they get infected and may transmit the disease, but what is the impact on that is unknown. Also, the immunity of the people against various viral infections and the general immunity and vaccination status of people against other diseases is different. So there is a lot of talk about aspecific immunity. Also, there is some genetic factor that is being discussed. So we don't know how all these differences will play out, but it is a very obvious observation that till now no major epidemic occurred in a tropical climate. So we hope that will be confirmed, but we prepare for the worst. A second factor is that COVID-19 caused by this coronavirus is a new disease. So a lot of comparisons are made with influenza, but this is not a new disease, influenza, that comes back every year. So what is now very, very crucial is to understand what immunity will be triggered by this virus. And that can vary widely. It is possible that after a first infection of a viral disease, you get a very strong immunity and you cannot get this disease anymore for many years, or even lifelong, like in the case of measles. It's also possible that the protection is only very minimal and that you can quite easily next year get a reinfection or even earlier than next year. So that's unknown. It's even possible that first infection produces some immunity, but that is immunity enhances later infections and make them worse. All that is possible, it's unknown, although the most likely seems that there is some immunity, but that it will not be very robust, so that you can be reinfected after 1 or 2 years. But again, this is very uncertain. The third point I want to mention is the role of international organizations. In countries such as Congo or in many African countries, usually there is a huge reaction of the international community when such a big epidemic occurs, like for instance in Ebola. Now the situation is quite different because it's not Ebola in one area, but there is coronavirus everywhere. So the organizations who have a mandate to react, like WHO and African CDC, they are very, very thinly spread, and for the moment they don't give priority to DRC, although they are here, but relatively low profile. So the governance of the epidemic is really, really in the hands of the Congolese coordinator team. Also, due to travel restrictions, it's very difficult for international staff to come, and in fact, the opposite is happening. Most expatriates are traveling back to their home. For instance, there was quite a large team of CDC from Atlanta, from the United States here, but they have all been flown back to the US, probably because they are more needed in their own country for the moment than in Africa. also other international organizations like Médecins Sans Frontières. Many of their expatriate staff are returning to their home countries, and there are no new arriving. So this creates, I think, quite a different international landscape than in previous epidemics.